Let's turn the spotlight on growth hormone, or GH, also known as somatotropin. It's one of the most talked about hormones in medicine, and for good reason. If the pituitary is your hormone translator, GH is its star performer, essential for growth, metabolism, and adaptation to fasting. GH is essential for growth, but it doesn't act alone. Here's a key point. If you remove the pituitary, growth stops, even if you replace thyroid hormone, adrenal steroids, and sex hormones. Only when GH is added back in does growth resume. But GH alone isn't enough either, you also need proper nutrition, adequate insulin, a healthy thyroid, and overall well-being. So think of GH as a team captain, not a solo act. GH secretion, pulses, sleep, and control signals. GH is produced by somatotrophs, which make up over a third of the anterior pituitary. Its release is tightly controlled by two hypothalamic hormones. GHRH stimulates GH release. Somatostatin, SS, inhibits it. GH is released in pulses about every 2 to 3 hours. With the biggest, most consistent surge occurring right after you fall asleep. And between pulses, levels drop so low they're sometimes undetectable. Which makes random GH tests pretty unreliable in clinical practice. That's why we use IGF-1 as a more stable indicator, more on that in a bit. GH is an open-loop hormone. Unlike many tightly closed feedback systems, GH operates in an open-loop system. Meaning its release is influenced by multiple external factors, including sleep, exercise, stress, blood sugar, other hormones. It's not just on autopilot, it's constantly adjusting to your environment. GH has dual roles, anabolic and catabolic. GH is known as an amphibolic hormone, it supports both building and breaking down, depending on the body's needs. Let's break it down. Catabolic effects, energy mobilization. Promotes lipolysis, breaks down fat to provide fuel. Stimulates gluconeogenesis in the liver. Antagonizes insulin, reducing glucose uptake in tissues, raising blood sugar. Preserves glucose for the brain during fasting. That's why GH deficiency in kids can cause hypoglycemia, and in adults, especially if ACTH is also low, hypoglycemia can still occur. Anabolic effects, tissue growth. Stimulates protein synthesis in muscle. Promotes bone growth and phosphate retention. Leads to positive nitrogen balance. In short, GH helps you build up when fed, and survive when fasting. Indirect effects, the IGF-1 axis. Many of GH's growth-promoting effects are actually mediated by IGF-1. Insulin-like growth factor 1, formerly called somatomedin C. Here's the flow. GH stimulates the liver to produce IGF-1. IGF-1 acts on bones, cartilage, and muscle to stimulate growth. IGF-1 circulates in the blood bound to carrier proteins, mainly IGF-BP3. These binding proteins regulate how IGF-1 works, and they may even have roles in cancer biology, especially colorectal cancer. Testing GH function. Because GH is secreted in unpredictable pulses, we rely on more stable markers. Screening tests. IGF-1 reflects average GH levels over time. IGF-BP3, often used alongside IGF-1. Low IGF-1 could mean GH deficiency, or malnutrition, diabetes, or chronic illness. High IGF-1 suggests GH excess, like acromegaly. Confirmatory tests. Oral glucose suppression test. For suspected acromegaly. After a 100 g glucose drink, GH should fall. If GH doesn't suppress, that's diagnostic. GH stimulation tests. For suspected deficiency. Agents like GHRH plus arginine, or L-DOPA plus arginine are used. GH should rise greater than 3 to 5 nanograms per milliliter. If not, deficiency is likely. In some cases, if IGF-1 is very low and the patient already has known pituitary damage, we might skip the stimulation test altogether. Let's talk about what happens when growth hormone goes off the rails, either too much or not enough. GH excess, acromegaly and gigantism. Acromegaly is the result of GH overproduction, most often due to a pituitary adenoma. If the GH excess happens before the epiphyseal plates close, in children, you get gigantism, dramatic increase in height and bone length. But in adults, once the growth plates are fused, you get acromegaly. Clinical features of acromegaly. Enlarged hands and feet. Coarsened facial features, broad nose, large jaw, thickened brow. Gaps between teeth. Soft tissue swelling, like lips, tongue, and skin. Arthritis from joint overgrowth. Organ enlargement, especially thyroid. Sweating and heat intolerance. Sleep apnea. Insulin resistance or diabetes. Hypertension and heart disease. And in about 40% of cases, the tumor also secretes prolactin, leading to combined symptoms. Acromegaly is sneaky, changes happen gradually, and many patients don't notice until someone compares old photos or symptoms like headaches and vision problems bring them to a doctor. Diagnosis of acromegaly. Elevated IGF-1. Failure of GH to suppress after oral glucose load. MRI to confirm a pituitary mass. Treatment of acromegaly. First line. Transsphenoidal surgery to remove the tumor. If not fully successful, radiation, external beam or focus therapy, may take years to normalize GH. Medications. Somatostatin analogues, as octreotide, lanreotide. Dopamine agonists, as cabergoline, bromocriptine, especially if prolactin is co-secreted. GH receptor blockers like pegvisomant, which block GH action at its receptor. The goal, normalize GH and IGF-1, preserve pituitary function, and minimize long-term complications. GH deficiency. This can occur in both children and adults, and the causes, and consequences, vary. In children. Causes. Genetic mutations affecting GH production or action. Developmental anomalies. Pituitary tumors, e.g., craniopharyngioma. Radiation or surgery. Symptoms. Poor linear growth/short stature. Delayed puberty. Increased fat, especially abdominal. Hypoglycemia, especially in infants. Some children may have GH insensitivity, where GH is present, but the receptors or downstream signaling are defective. These include defects in GH receptor, IGF-1 production, IGF-1 receptor, post-receptor signaling pathways. These patients don't respond to GH therapy. In adults, GH deficiency is often part of panhypopituitarism, caused by pituitary tumors, surgery or radiation, traumatic brain injury, or just aging, which naturally lowers GH levels. Symptoms in adults. Fatigue, low energy, and social withdrawal. Loss of motivation, poor sense of well-being. Reduced muscle mass, increased fat mass, especially abdominal. Osteoporosis. Increased cardiovascular risk. While these symptoms can be subtle, multiple studies suggest increased mortality in GH-deficient adults. Treatment for GH deficiency. Recombinant human GH therapy is available. Administered as a daily injection. Benefits. Improved muscle mass. Better body composition. Enhanced quality of life. Main drawback. Cost, it's expensive and not always covered. But in the right patient, especially younger adults with documented deficiency, GH therapy can be life-changing. Now let's explore another direct effector hormone from the anterior pituitary, one that plays a critical role in reproduction. That's prolactin. What is prolactin? Structurally similar to GH and human placental lactogen. Not a tropic hormone, it acts directly on target tissues. Most famous for one thing, stimulating milk production. But it's also considered a stress hormone, and plays roles in immune function, behavior, and reproduction. Unique regulation, prolactin is usually on hold. Here's what makes prolactin really unique. Unlike other pituitary hormones that are stimulated to release, prolactin is kept in check by tonic inhibition. The inhibitor. Dopamine, acting through D2 receptors on lactotroph cells in the anterior pituitary. So, less dopamine equals more prolactin. Anything that blocks dopamine removes the brakes on prolactin release. What causes elevated prolactin? Several things can lift the brake. Medications, especially D2 antagonists. Antipsychotics. Antidepressants. Metoclopramide. Methyl-dopa. Stalk disruption. Tumors, trauma, inflammation that block dopamine from reaching the pituitary. Hypothyroidism. High TRH, thyrotrophin-releasing hormone, can stimulate prolactin. Estrogens. Stimulate prolactin production, especially during pregnancy. Reflexes and stress. Suckling, chest wall injury, seizures, exercise, emotional stress. Systemic conditions. Chronic kidney disease. Polycystic ovary syndrome, PCOS. What does prolactin do? Main role. Stimulates milk production in the postpartum breast. Secondary effects. Suppresses reproduction. Inhibits GnRH, leading to lower LH and FSH. This leads to hypogonadism. Explains delayed ovulation in breastfeeding women. High prolactin equals low estrogen or testosterone equals infertility, bone loss, and more. Prolactinoma, the most common functional pituitary tumor. A prolactinoma is a pituitary adenoma that secretes prolactin. Who gets it? Premenopausal women often present with amenorrhea, galactorrhea, infertility. Men and postmenopausal women often present later with headaches or visual disturbances, decreased libido or erectile dysfunction. Sometimes osteoporosis due to long-standing hypogonadism. Diagnosing high prolactin. Start with thorough history and physical exam. Check TSH and free T4, rule out hypothyroidism. If a tumor is suspected, get MRI of the pituitary, sellar region. Other pituitary hormones, cortisol, LH, FSH, estradiol/testosterone. Prolactin levels help differentiate. Greater than 150 nanograms per milliliter likely prolactinoma. 25 to 100 nanograms per milliliter could be from meds, stock effect, or other causes. Also, be aware of macroprolactin, a biologically inactive 150 kDa form. It shows up in lab tests as elevated but doesn't cause symptoms. You can test for it with polyethylene glycol precipitation. Treatment of prolactinoma. Goals. Shrink the tumor. Restore fertility and hormone balance. Prevent osteoporosis. Preserve full pituitary function. First line, dopamine agonists. Cabergoline, preferred longer-acting, fewer side effects, bi-weekly dosing. Bromocriptine, older, can cause nausea, sometimes given intravaginally to reduce GI issues. These drugs work in greater than 90% of patients, restoring menses and fertility in many. Usually stopped during pregnancy, unless there's concern about tumor regrowth. Surgery. Transphenoidal resection if medical therapy fails. There's visual loss, tumor hemorrhage, or a large cystic tumor. Surgical success is lower with larger tumors or very high prolactin levels. Radiation. Reserved for aggressive macroadenomas. Poor surgical candidates. Dopamine agonist-resistant tumors. Idiopathic galactorrhea. Sometimes, women produce milk with normal prolactin levels, especially after multiple pregnancies. That's called idiopathic galactorrhea, and it's usually harmless. Just make sure other causes are ruled out first. We've covered what the pituitary does, now let's talk about what happens when it doesn't do its job. That condition is called hypopituitarism, and it means a loss of anterior pituitary function. It can affect just one hormone, called a monotropic deficiency. Or all anterior hormones, that's panhypopituitarism. What happens when hormones go missing? If you lose tropic hormones. ASCP adrenal insufficiency. TSH hypothyroidism. LH/FSH hypogonadism. These directly affect target organs like the adrenal glands, thyroid, and gonads. If you lose direct effector hormones, GH and prolactin, the effects may be subtle, but still important, especially in children or when fertility is an issue. How to diagnose hypopituitarism? This is where clinical biochemistry shines. The key is to measure both the tropic hormone, from the pituitary, target hormone, from the end organ, and compare. Example, hypothyroidism. Primary hypothyroidism. Low free T4. High TSH, the pituitary is working overtime. Secondary hypothyroidism, pituitary failure. Low free T4. Low or normal TSH, inappropriately low. That's the red flag. This logic applies to adrenal, gonadal, and thyroid axes alike. Important clinical tip. If you find one hormone deficiency, always check for others. And never start a patient on thyroxine until you've ruled out ASCP deficiency. Why? Because replacing thyroid hormone in someone with untreated adrenal insufficiency can trigger an adrenal crisis, which is life-threatening. So always start corticosteroids first when needed. Causes of hypopituitarism. Let's break them down. 1. Tumors, most common. Large pituitary adenomas, compress healthy tissue. Paracellular tumors, e.g., meningiomas, gliomas. Metastases, often from breast or lung cancer. Hypothalamic tumors, like craniopharyngiomas. 2. Pituitary apoplexy. Sudden bleeding into a pituitary tumor. Can cause instant pituitary failure. Presence with severe headache, visual loss, or even shock. 3. Sheehan syndrome. Postpartum pituitary infarction due to severe blood loss during delivery. Often presents as inability to lactate and fatigue shortly after birth. 4. Infiltrative diseases. Hemochromatosis. Sarcoidosis. Langerhans cell histiocytosis. These can disrupt pituitary or hypothalamic function. 5. Infections. TB, syphilis, fungal infections, less common today, but still important in certain regions. 6. Autoimmune hypophysitis. Especially seen in women postpartum or in patients receiving checkpoint inhibitors like ipilimumab, for melanoma. 7. Trauma or surgery. Head injury. Neurosurgery involving the sellar region. Or even radiation therapy, where damage can occur gradually, over years. 8. Genetic causes. Example, Kallmann syndrome, a rare cause of GnRH deficiency, leading to secondary hypogonadism. 9. Idiopathic. Sometimes, no clear cause is found. But ongoing monitoring is crucial, as a cause may emerge later. Treatment of panhypopituitarism. Treatment equals replace what's missing. Usually includes glucocorticoids, e.g., hydrocortisone, always start this first. Thyroxine, T4. Sex steroids, testosterone or estrogen/progestin. Sometimes, GH, especially in children or symptomatic adults. Special case, fertility. Restoring fertility takes more than just hormone pills. You may need pulsatile GnRH therapy, mimics natural rhythm to induce ovulation/spermatogenesis. Or direct gonadotropin injections, LH and FSH analogs. It's more complex, but with the right regimen, many patients do conceive successfully. We've covered the anterior pituitary and its many hormones. Now let's wrap up this deep dive with the posterior pituitary, which, unlike the anterior lobe, doesn't produce hormones, it stores and releases them. Specifically, two critical ones. Oxytocin. Vasopressin, also called ADH, antidiuretic hormone. Posterior pituitary, structure and origin. The posterior pituitary is actually an extension of the forebrain. It's directly connected to the hypothalamus via the hypothalamo-neurohypophyseal tract. These two hormones, oxytocin and vasopressin, are synthesized in the hypothalamus, specifically oxytocin, in the paraventricular nucleus. Vasopressin, in the supraoptic nucleus. Then transported down axons through the pituitary stalk. Stored in the posterior pituitary until released into the bloodstream. They also travel bound to a carrier protein called neurophysin, which may help stabilize or transport them, though its exact role is still not fully understood. Oxytocin, the bonding hormone. Oxytocin is a nonapeptide, 9 amino acids, with a cyclic structure. Main roles. Milk letdown, it contracts myoepithelial cells in the breast to eject milk during breastfeeding. Uterine contractions, during labor, oxytocin helps initiate and maintain labor contractions. Maternal bonding, it plays a huge role in mother-infant bonding, emotional connection, and nurturing behavior. Synthetic oxytocin, called pitocin, is often used to induce or strengthen labor. Other possible effects may influence heart, kidney, and immune function. Has been linked to social behaviors, emotional regulation, and trust. We're still learning just how far oxytocin's reach goes. Vasopressin, ADH, water balance and vascular tone. Like oxytocin, vasopressin is also a nonapeptide, structurally similar, differing by just 2 amino acids. Its primary job: water conservation. Action on the kidneys. Vasopressin binds to V2 receptors in the renal collecting ducts. This triggers insertion of aquaporin, 2 channels into the membrane. Result: water is reabsorbed, urine becomes concentrated, and blood volume increases. This is essential for maintaining plasma osmolality. Other effects. V1 receptors in blood vessels cause vasoconstriction, increasing blood pressure. Promotes release of clotting factors. Factor VIII, from the liver. Vaughan-Willebrand factor, from the endothelium. So vasopressin is both a water-saving hormone and a vasopressor. How is vasopressin regulated? It's a tightly controlled feedback system, with 2 major inputs. 1. Osmoreceptors, in the hypothalamus. Sensitive to plasma osmolality. As osmolality rises, more concentrated, vasopressin increases. Promotes water retention, dilutes plasma back to normal. Average osmotic threshold, 284 mosm/kg. 2. Baroreceptors, in the heart and arteries. Detect blood pressure and volume. A 5 to 10% drop in blood volume or pressure, powerful trigger for vasopressin release. This response can override osmotic control. It's a survival mechanism. During shock or dehydration, preserving blood volume becomes top priority. Diabetes insipidus, DI. When vasopressin is deficient or ineffective, we get diabetes insipidus, very different from diabetes mellitus. Classic symptoms. Polyuria, excessive urination. Polydipsia, intense thirst. 2 main types. Central DI. Brain doesn't produce or release enough vasopressin. Causes: autoimmune destruction, head trauma, pituitary stalk injury, tumors. Idiopathic, 30% of cases. Nephrogenic DI. Kidneys don't respond to vasopressin properly. Often genetic or drug-induced. Diagnosis: measure serum and urine osmolality. In DI, serum osmolality is high. Urine osmolality stays low. Water deprivation test can help assess the ability to concentrate urine. Trial of desmopressin, DDAVP. If symptoms improve, central DI. If no improvement, nephrogenic DI. Treatment: for central DI, desmopressin, DDAVP, a vasopressin analog. Available as nasal spray, tablets, or injection. Highly effective and well tolerated. For vasopressin excess, e.g., SIADH. Syndrome of inappropriate ADH secretion equals too much water retained, low sodium. Treatment includes fluid restriction. V2 receptor blockers like conivaptan, tolvaptan. These help restore sodium levels and promote water excretion. Thanks for joining me in this deep dive on the pituitary. If you found this valuable, don't forget to like, subscribe, and stay tuned for more detailed breakdowns, right here on ASCP Preparation Camp.